a 50-year-old, 40-year-old, wana slay kabisa, hata wanaweza patia hao 25-year-olds run for their money. Okay?
Yeah.
However, their biology is not going to lie. Remember, I think the song was just, there was Shakira.
Yes.
So they say hips don't lie. No, say biology does not lie.
Biology does not lie.
Biology does not lie.
ticking.
It's ticking.
Yeah.
What?
So, what science tells us, and what I'd want all young women to hear, is that for those who aspire, because again, modern life has come with their people come to my office to tell me I don't want to be a mom, and I'm just like, cheers. I don't necessarily agree with you. However, it's your life. It's your choice to make, and really that's your choice to make. Asked to advise them differently, because I'm also a mother, and I think it's one of the most rewarding things that has happened to me in my life. So I think that could also be my pink, my kids and my family.
That's beautiful.
For women, we know we are at peak fertility up to the age of about 35. Yeah. So if you want to have a family, you should be planning to have a family before you reach the age of 35. We're not saying you can't have kids beyond 35, okay? But what we're saying is that your fertility drastically and rapidly drops after the age of 35, and that's in the general population, okay? And so you need to be working on fertility issues when you're at peak fertility, not when your fertility is declining. Not when it's declining, okay? There are those people, fine, they have reached, we're here, we are 40, what do we do? Of course, we'll still try to assist them, okay? But you want to have a family, understand? Please try to plan to have this family before 35. You plan for everything. You plan for first degree, second degree, PhD, masters, your test, CG jobs, you nataka kuwa, CG director, I don't know where.
And then you become the director.
Yet, I feel the most important part of your life, which is your family, why aren't we planning for it appropriately?
Okay.
Yeah.
So, Dr.
What a start.
Dr. has put it really well and really hit the nail on the head, I would say. But Dr. I have a question. What are some of the first signs, that something in your reproductive system needs attention, when there may be? What
problem in order to be seen. We know that as women, annually you should be having a visit with your gynecology. Okay, with your gynecologist. Okay, let me not use that big word. That big word you only use when you're pregnant. Obstetrician. Yes. I don't want to stress my dear.
The OB.
So it's the same doctor, okay, generally. Just the difference is an obstetrician is your gynae during your pregnancy journey. Okay. Yeah. When you're not pregnant, it's a gynecologist.
When you're pregnant,
it's an obstetrician.
Interesting. I never knew that.
Okay. See, obstetrician is when
what were we saying again? I forgot.
I asked you, what are the first signs that...
so we're saying that you should be seeing your gynae on an annual basis. We do things like screening for cervical cancer, screening for breast cancer, just making sure that you're healthy, okay? We're in the modern world, and I think it is very sad, okay? I think we lost one of you not too long ago, and this is an icon. This is somebody we all grew up, watching, and it's so sad that we can have a death from cervical cancer, yet cervical cancer is the only known cancer that's preventable today. Okay. And how we prevent cervical cancer is by screening women on a regular basis. Okay. We pick up what are called precancerous changes. Okay, so when we do a pap smear, we're able to pick up precancerous changes on your pap, or we nowadays do what is called HPV DNA testing. We're able to find out whether you have the high risk HPVs, and able to do tests and treatment that will stop you from progressing to get cervical cancer. So for me, a woman dying from cervical cancer in this age, I think it's one of the saddest and most horrific things that's happening, because it's preventable.
It's preventable.
You understand?
Yeah.
You see, like the difference with breast cancer, even breast cancer is something picked up early. Yeah? You'll be treated and you will live tumor-free for a long time. Yeah? And even those who have it, it's one of those treated at the right time. Asked if there are two cancers, like if someone told me I must get cancer, which cancer would I choose? I'd choose cervical or breast. You understand? Because cervical, I could have prevented it. You understand?
Yes.
And breast, if I treat early, you see breast cancer survivors 15 years, 20 years.
True.
There are very few other cancers that you see those survivors long term. You understand? And it's because we've picked you up early, treated you at the right time, and you're going to live a long and productive life. So you should have regular checks, even if it's not a gynecologist, but at least have an annual check with a healthcare provider, so that these things are being done, your screening is being done. And along with all these other things, you have the lifestyle diseases, hypertension, diabetes, all of that. Picked up, we discover, Nini, managed. We'll stay till our hundreds. Tukiwa tu.
Is a secret. And nowadays, other than cancer, we have fibroids and cysts. They've almost become like a rite of passage. God forbid, like for women. You'll hear a surgery here, it's fibroids, cysts. Why are they so common? Were they common back then?
Okay, so let me start with the more common, which I feel is fibroids. Okay, now what has changed? I think that will be the question. What has changed is that for Africans, if I'll say maybe 100 years ago, somebody my age would probably be having 12 kids. If I didn't have a fertility, or my husband didn't have a fertility issues. Fibroids is a disease of an idle uterus. The work of your womb or uterus is actually to carry babies. Yeah, I know there are those who are going to differ. Women's rights, Nini, my right, my choice.
And I don't.
But that is the work of the uterus. Your work of uterus is not to give you periods. No. The work of your uterus is to carry your baby. And the moment the uterus is not doing its work, I love one of my lecturers, and used to say that a fibroid is that baby. Itatafuta ile itabeba.
Oh no!
It's looking for something to.
It's looking for something to carry. And so having children is actually protective against getting fibroids. So we're now, it's not that fibroids are not there, it's just that in the olden days, by virtue that women used to have several children, it was protecting them from getting fibroids. So fibroids, you see nuns,
Yes. Oh, really?
Yes, because they're not getting pregnant. It's not active. And all these women who are now deciding, I don't want to get married, I don't want to get kids. And remember, fibroids in the African race, I think we have the highest predisposition towards fibroids from among all races. So just being it's like that. It's like it's like we know getting twins unaenda Nigeria. The highest incidence of twins in the world. There are certain diseases which are race specific. Now, for Africans, fibroid is one of those where just being African is a risk factor for getting fibroids.
Yeah. What of cysts?
So cysts again, I didn't want to start with the cysts.
Okay.
You understand? Because cysts, unfortunately, it's too broad a term. Okay. So for me, cysts can occur anywhere in your body, but I'm sure the cysts you're referring to are on the ovaries.
Yeah.
Okay. So talking about ovarian cysts. And even for me, an ovarian cyst, depending on size and the time of your cycle, for me can be a normal finding. You understand? Yeah. And then there are what we have abnormal findings. Okay. So I think you two look like you're still reproductive age.
Yes,
yeah.
yes.
So if around time of ovulation and after ovulation I don't find a cyst, I'll be concerned for you. Be like, hey, what's not happening? Your biology is not working, because before you ovulate, you form what we call a follicular cyst, and that's normal. And after you ovulate, there's that cyst that persists to maintain the pregnancy if you get pregnant, and then it disappears around the time of your period. If you're not pregnant, it continues growing until the placenta takes over if you're pregnant. So cysts, for me, we'd have to look at it. I think you're talking about pathological cysts. So a cyst for us, more than 5 centimeters on the ovary, that for me now would be something pathological. Anything less than that, we just observe over time what's happening and make a conclusion depending over time. If it's growing, okay, we can do something about it. It's regressing or disappears. What am I doing about it? So another common thing, what I know, is something called polycystic ovarian syndrome. So these are young women who have problems with their it's a hormonal problem primarily that affects like their sugar metabolism. So what happens is they're not ovulating, and then you find on the ovary you have multiple cysts arranged around the edge of the ovary, and we call it a pearl necklace appearance. I love medicine. We always relate what we're seeing with where.
You call it a pearl.
Yes. So the way you see a pearl necklace, the way it looks like that or when you do an ultrasound.
For PCOS.
Yes, for PCOS. So okay, it's one of the findings. I don't want to go too deep into it. So it just depends on what type of cyst is it, what's the location, what's the size, time of the cycle. Okay, is when we discover. So not all cysts are bad. Okay, but like everything, even fibroids, okay? Someone can have multiple fibroids. They don't have symptoms. Leave you alone. Even the cysts, what is it causing for you? How is it disturbing you?
And why does it take so long to diagnose PCOS and endometriosis too? Like you find, women in and out of hospital over time, painful periods, then eventually diagnosis comes as PCOS. Why does it take so long?
Probably. I don't think it takes so long. Maybe the caliber of healthcare provider you're seeing. I think any gynae you'll see within 2-3 visits, you would have a diagnosis. The one that is challenging is obviously endometriosis. Okay, but at least for us nowadays, for endo, we have moved away from you must 100% have a histological diagnosis. So histological diagnosis means you need a biopsy, okay, which has been taken to lab and confirmed that this is endometriosis. Meaning, unfortunately, where am I getting that biopsy from? You have to undergo surgery. Okay, So for endo, that has been the diagnostic quagmire. But nowadays, we don't necessarily need to go into surgery before somebody's able to diagnose endometriosis.
Okay.
So it's just it's what is the history, how it's going, and some things you'd really have to see over time. But for endo, for me, it's anyone who's really having severe menstrual cramps, and these cramps are severe enough that you're not able to function. So I think most of us remember there was always this time of periods when we're Tukiwa high school. They can't go to class. Understand? So when you have pain, to that extent that really you can't even get out of bed, you can't go to work because of the excruciating pain you're going in through, probably it's not normal. Please, 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 urgently see a doctor, see how we can help you. One, get a diagnosis, and two, get treatment for it. Yes.
Yeah.
Okay.
We have really little time, and I feel like we still have so much to talk about.
The one thing I feel like is very important now that we've talked about my periods are here, you're taking a step by step. Are we at what do we call them? IUDs and all that, contraceptives. Are we there, Daktari? And how do I determine what contraceptive to use without, these days there are influencers everywhere,
influencing everything.
Everything, even things that are as important. Yeah.
Okay.
So, Daktari, I want to know. Yeah.
Okay.
How do I choose the right contraceptive method for my body? Do I need to actually see a gyna before I choose that I'm going to use an IUD? Do I need your recommendation?
One,
tubal ligation, the new kid in town.
I don't think that tubal ligation is new. It's as old as it's a very old
method.
Old method
but
of
it's become
contraceptive.
So fashionable.
Yeah. So in principle, if somebody doesn't have any medical issue, you don't have cardiac disease, something strange. Contraception, remember, is something that's voluntary. Contraception is not a disease, okay?
Yeah.
It's just you want to control when, how, and the number of children that you're having.
Yeah.
Exactly.
Yeah. And so it's something that is voluntary, okay? And majority of the methods can be used by any normal person. So in terms of contraception, what I tell people, what I tell my clients, you are in the driver's seat of you choose, because first somebody, like personally, I know it's not good to refer to yourself. I know I'm a doctor, but if you tell me something that I have to take pills every day, you're giving me a very big headache. I don't want that story. I don't want that story. It's too much work, okay? Of course, there are certain times where you have to be very disciplined, but there's that person, you tell them an injection, they'll faint just for the sight of the injection. You understand? So the beauty about what we call, we have a method mix, you understand, to suit preferences of the different clients who would want to have contraception. So if you feel a pill's okay for you every day,
so
why not? Why not? Yes, you understand. You feel you want a long lasting, but and that's what we recommend, because in terms of efficacy and in terms of failure, and I think I'd like to say this so that people also understand, doctors, that there is no contraceptive that is 100%. Okay, so there's still what we call contraceptive failure. Okay, but if we're to look at the scheme of things, the longer lasting methods have a less chance of failure than the short acting methods. Okay. So, and because remember, short acting methods is under your control. You have to remember, take a pill every day, take a pill every day. You understand? You don't do that, risk.
High risk.
Yeah. So those methods that are not under your direct control would tend to work better than those which has an element whereby you have to do some actions on a frequent method. So that is that. So for me, contraception, contraindications would only be based on medical conditions. Okay, so it's always just good, just have with the healthcare, and you don't have to see a gynae to get access contraception. I think midwives, and we have nurses who are very well trained and very well versed in administering, and it's just us understanding how many people can afford to pay a consultation of 3,000 to 5,000 just to see the doctor, and then pay extra for the implementation of the method. So in the public sector, the midwives do it very, very well, and they're actually able to administer. So it's something you should feel that you have to see a doctor. But definitely, if you have a medical condition, it's now when we guide. that look, you're having a bleeding disorder, maybe use this. You're having a cardiac problem, use this. You're having diabetes, probably consider this. And it's again also, what medications are you taking? Because, for example, certain medications are going to hamper absorption of your contraceptives, so you would not be eligible to take because of the medication that you're taking. So for me, contraindication is purely on medical grounds. But you're just a normal person, hivi maisha ni mazuri. Please, ile unaona inakufaa, tumia hiyo.
Let me ask, if a woman has been trying to get pregnant without success, talking about fertility, how long should she try before, trying to seek help?
Okay.
When do you know, like,
I'm
So again, we classify women, again, based on age. Remember, we talked about age.
Yes. Well, the ideal situation in calendar where it's like Joyline, who is 24, she just got married and she's trying to...
Congratulations, Joyline!
She's going to reduce your minutes.
She told me that she's actually 21. So she's 21, was trying to have a child. How long should she wait, before she's adopted?
So, again, Joyline would be less than 35. Remember we said our magic number is?
Yes, 35.
You understand? So, any woman below 35, okay, who is having regular periods, okay? So, you can't say you're having periods once a year, you'll meet the same criteria. So, it's having regular periods. So, normal cycles are your 28, 30, and a regular cycle will be between 21 and 35 days. Okay? So, regular cycles, not on any form of contraception, and is having regular intercourse. So, regular intercourse, people think you have sex once a week and you're going to be pregnant. Yeah, you won't go. People.
How often?
Regular is
Let me just tell you.
It's functional. It's recreational.
Mimba inapenda wale hawataki. Siji kwa nini? You will have an oops. Hey, you will be so be pregnant. You understand? But ile wakati unatafuta, hey, ni kama inakuhepa. Okay? So, regular intercourse, so that is at least 3 times per week. And not Friday, Saturday, Sunday. At least spaced out for a week. Yeah. We normally give them about a year. Okay. They should be able to conceive. Like if everything, all parameters, constant and everything is okay, they should be pregnant within a year. Okay. They're not pregnant within a year, definitely they need to come see a specialist to find out what is not happening. Okay. So I've said that there's a magic number 35. Okay. Now, unfortunately, remember we've said that our fertility is rapidly declining after 35. So women over 35, we give them a shorter period. We give them 6 months to try. Why? Because they don't have all that time, because their fertility is going. So if you're over 35, we'll give you 6 months to try. You're not pregnant, come, let's help you when you're still salvageable. We don't want you to get to 40s and now we're scratching our heads. Your fertility is almost zero. Na sasa unakuja na you want me to perform miracles. Yeah, we'll perform them, but maybe not the way you want.
I think Daktari has brought us to the point where we can talk about the AMH, which is exactly what you were actually talking about.
Yes.
We are able to count the, ovarian reserve of a woman.
Okay.
Daktari, in an open book, if you just give us your insight on that.
Okay.
What is this test and at what point should we have it?
Okay.
Should we be having fertility testing?
Just to know.
Okay. So for me, I just say, in a normal things happen more commonly. So the common things happen commonly. So the beauty about life is most people are normal, okay? And most people, if they do things at the right time, you understand, should not have an issue. So your AMH test is like, for example, you've stayed that 1 year, you've done the prescription at Dr. Owiti, lakini mambo imeenda oxide. As I don't say oxide. Kogalo. Nasema ni oxide.
Offside.
See, offside. Ni oxide.
Hey.
So mambo imeenda oxide. So you come to us, and it's part of the things that we're going to do to help determine. And AMH, I wouldn't really concentrate so much on that figure. That figure is actually more relevant depending on the treatment that we are going to give you. Okay, more prognostic things that will tell us you're likely to conceive. If you're under 35, you have a higher probability of conceiving. So one of the most important, like if you want to prognosticate that I'm with a couple and they're going to have a baby, you understand? I'd prefer a woman who's under 35, and especially like in her 20s, whatever. That one, we're happy because she has higher chances.
Do we have similar measures for men?
Men are also affected. Men are also affected by age, but not as severely as women. So I always make a joke, sikwambaya anisamehe, but remember Njenga Karume died uko 18 alitoka akiwa na 3-year-old. So but it's up to the jury. You know, some of us, we're gynecologists. We have not very good minds, but it is okay.
Yes. So there are...
Yeah, we think widely. Yes. Lakini tachi hapo.
Tunakusikia. Yeah, that's really interesting to know.
So the AMH, definitely, we have what we call a critical level. Okay, so you have a level of 0.3. Okay, that is very, very low. That's a critical level. Okay. We want, like, what's the highest treatment we can give a woman? And for us, it is the IVF. Okay, if I want to perform IVF on a person with an AMH of 0.3, that one is just, I just want to take her money.
Wow.
Yes, I am not trying to treat her.
The chances are...
It's not good.
Slim.
It's very, very slim. Okay, so that one definitely we don't stimulate. So it's more for a stimulation perspective. Yeah. So having a low AMH does not mean you cannot conceive. You understand? All it's telling you is that your chances are much lower than somebody who has a higher AMH. Okay. And for us, it's more on a treatment perspective. You're hardly going to get a response from the treatment, because when we're doing IVF, we want that we're able to harvest many oocytes. Okay. And many oocytes come, like a young person, they'll have at the beginning of the cycle waves whereby they have multiple oocytes. Okay. A person with 0.3 will only have one oocyte. Why am I pumping this person with so many hormones to retrieve one oocyte? I'm making sense. What's
the uptake of IVF in Kenya? Like, do we still have the cultural barriers?
I think the barriers is not cultural. It's more stigma.
Oh.
Yes, it's more stigma. Fertility is one of those things, okay? You don't find someone telling you, oh, guys, I can't conceive. Yeah. I may share with you that I have cancer. You understand? I'll share with you that I have diabetes, okay? But there's certain diseases you won't share with somebody. And these reproductive health diseases, I'm not going to tell you I have an STD. I'm not going to... I get it. So you find that it's more of that stigma. We find that it's a very personal type of thing. So it's a very lonely journey because you don't feel empowered to share with other people, and even you feel embarrassed to share with other people that I can't have children. Okay, so for me, it's once they access care, the main barrier is actually cost. Okay, because an IVF cycle, give or take, is anywhere between 500 to $1 million, depending on who your service provider is. And I think you're aware not very many people are going to be able to access that type of money. Yes.
Daktari, I know we have 3 minutes, but someone has DM'd me. It's a listener who is asking. She's over 35, so she's asking how can we just a minute. What are some of the habits that then women who are over 35, as you're saying, should drop immediately because it harms their reproductive health?
Okay, and I think it's regardless of whether you're 35 or under 35.
Yeah.
Okay, we all know the main vices: alcohol, smoking, drugs. These hamper your health, they hamper your fertility, and more so can affect your unborn baby. Okay, so we know that you intend to be pregnant. It's obvious that you should not be doing some of those things. What are some of the things that you should be doing? We all know balanced, nice, healthy diets, drink a lot of water, exercise. Sleep, very important, by the way. Yeah. Okay. Unfortunately, I'm a gynae. I may not qualify. That's my bed. That's my phone. My bed I chose, and I'm sleeping in it with all the thoughts. But generally, sleep is very, very important for your general wellness. Even like these things, like even weight management and stuff like that. People will go exercising, and yet your issue is sleep.
Wait.
We're here, but it's okay. There are other things, kuna hizo constitutional, familiar, you know, me and my family sisi tuko tumejenga vizuri sana generally, but there are some things, by the way, you're doing all the right things, but not getting adequate sleep. It's not going to add to
mental health.
Too
We
much.
have a wellness coach that's coming on the Pink Lab after this.
Okay.
Maybe she's going to delve more into that.
Yeah.
Yeah.
So that one is for regardless.
Yes.
Under 35, over 35, those are just general rules.
Take care of your
Look
body.
after yourself. Be healthy. Enjoy life. Okay. And I like that you were saying there's a wellness coach. I think your mental well-being, just having that positive,
vibe around you.
Yeah. You need
Pinking
to,
around.
Not that pink for you means positive. Pink away.
Sorry, we have literally 25 seconds. Give us your closing remarks. I mean, this masterclass has been fun and all that. We're all laughing. Please give us your final word.
No, for me, it's just let's look after ourselves. And for those of you who want to have families, please, let's think about it at the right time.
Please, that is very important.
Very important. So I'm in Upper Hill at 40 Suits. It's called Gynecare on the 7th floor. And our office number is 0768 450 622.
All right, guys. Mumesikia daktari. Daktari has told you that you take care of your bodies, whether you're having functional sex or recreational sex. Just take care of your health. Sleep enough.
Was that your take? I'll tell you.
Something like that. I agree with her.